we have Dr. John Apostolidis. He is a consultant hematology and bone marrow transplant, King Fahd Specialist Hospital, Dammam. He's going to present two abstracts. The first one is Nivolumab for relapsed refractory classical Hodgkin's lymphoma after autologous transplant, 5-year overall survival. And the second abstract with going to be CAM-T, which is a conjugate antibody, an open label multicenter phase 2 study in a patient with relapsed refractory classical Hodgkin's lymphoma. Dr. John, go ahead, please.
Thank you for the introduction. I would like to thank the Saudi SSBMT and the Saudi Lymphoma Group for giving me the opportunity to present these abstracts. The first presentation is updated 5-year results of the phase 2 CheckMate 205 study, in which patients who had relapsed or refractory Hodgkin's lymphoma who had failed autologous stem cell transplantation were treated with Nivolumab. So PD-1 blockade therapy is now standard of care for most patients with relapsed refractory Hodgkin's lymphoma, and this is based on the results of clinical trials that show that these agents have activity in the Hodgkin's lymphoma. And one of these studies was the pivotal CheckMate 205 study, in which results were presented at a time point of 18 months, as you can see here, and 33 months, and in which the results were quite similar. Now, we also know that PD-1 inhibitors as monotherapy in a randomized fashion have shown that they improve progression-free survival when compared with brentuximab in the relapsed refractory setting. What we don't know is the long-term survival benefit of anti-PD-1 therapy and the optimal duration of treatment in these patients. So the updated results of the CheckMate 205 study with a median follow-up of 5 years is looking into these questions. And just to remind us all of the study design, patients with relapsed refractory Hodgkin's lymphoma who had previously undergone auto stem cell transplantation were enrolled into the study. There were 3 cohorts. Cohort A, which included patients who were brentuximab vedotin naive. Cohort B, which included patients who had received brentuximab vedotin after auto stem cell transplantation. And cohort C, which included patients who had received brentuximab vedotin before and or after auto stem cell transplantation. Treatment was continued until disease progression or unacceptable toxicity. And a particular interesting part of the cohort C was that patients who had achieved CR that lasted at least a year per protocol discontinued treatment and were retreated if they'd relapsed within 2 years. Data cutoff, the database lock was met in January 2021. Here we can see the patient's disposition. Sorry. Now, as you can see here, there are 19 patients who are still on treatment. As regard to patients who went off treatment, the vast majority of these patients, as you can see, 40% was due to progressive disease, while 10% of patients went off study due to treatment-related toxicity.
Yes. Can you switch off your camera and switch it on, please? It's not clear, actually.
Oh, sorry. Is it okay now?
No, it's not clear. Yeah, that's right.
Okay. Now, regarding patients, there was a proportion of patients, 24 patients who went on to a subsequent stem cell transplant associated with a benefit they achieved when treated with Nivolumab. And of these 24 patients, the majority, it's 23, went on to receive allo stem cell transplantation, while one of these patients from cohort A received an auto stem cell transplant. Sorry, I'm having difficulty. Oh, okay. Here we can see the adverse events. And as you can see, 82% of patients developed adverse events, and 82%, sorry, and 28% developed grade 3 or 4 adverse events, which do not differ with those presented in the previous analysis of the study, suggesting that with long-term treatment, the side effects, there have been no new serious side effects. Here we can see the immune-mediated adverse events. As you can see here, a proportion of patients developed adverse events of immune-mediated of any grade, but if we focus on the grade 3 and 4 immune-mediated adverse events, they are very few numbers, so you consider this toxicity quite small. Now, if you look at the best response after extended follow-up, you can see that the overall response rate was 71%, and ranging from 65 to 75%. The CR rate was 21%, as you can see. Now, with regard to the CR rate, it was 16% at 33 months of follow-up, and it increased to 21% at 58 months of follow-up. But this is due to data cleanup, confirming responses that had not been previously seen, rather than late response to treatment. If we look at the duration of response by best overall response, we can see that the median duration of response for all responders was 18.2 months. But as you can see here, patients who achieved complete remission had a very good, very favorable outcome. As you can see, the median duration of response was 30.3 months in these patients. And if we look at progression-free survival, the median progression-free survival ranged from 15 to 18 months, and overall it was 15.1 months. And we can still see that the 5-year progression-free survival is 18%. Again, if we break down progression-free survival by best response rate, we can see that those who had the most favorable outcome are those who achieved CR. We can see that the median progression-free survival was 37.4 months for patients who had achieved CR. And if we look at the overall survival of the patients, we can see that the 5-year overall survival has not been reached, and it's 71.4% at 5 years. And again, if we break it down by best response, we can see that the patients who had achieved a CR had excellent overall survival, as you can see. But one could argue that also patients who achieved a partial remission or stable disease also had prolonged overall survival. Interestingly, even in patients who had progressive disease, there's a proportion of these patients who are still alive, mainly due to the incorporation of salvage therapies after failure of the immune checkpoint inhibitor. Now we focus on patients in cohort C. These are patients who discontinued treatment after at least a year of persistent CR. In total, these are 12 patients. As you can see here, 6 patients maintained their remission on follow-up. Of the remaining 6 patients, 4 progressed. 1 of these received commercial Nivolumab off study. 3 patients were retreated per protocol, and 1 of these patients continues to be treated and is disease-free at almost 3 years. So in conclusion, the 5-year follow-up of the CheckMate 205 study confirms the efficacy of Nivolumab for patients who have relapsed Hodgkin's or recovered Hodgkin's lymphoma and who have progressed or relapsed after auto stem cell transplantation. We can see that in a proportion of these patients, the responses are durable and with extended follow-up, in particular for patients who have achieved complete remission. And the favorable overall response was observed with long-term follow-up in all categories of patients. Regarding the adverse event profile, with extended follow-up, there were no new signals of adverse events. And although a limited number of patients, it seems feasible to stop Nivolumab after 1 year of complete remission and reinitiate treatment upon disease progression. So these are acknowledgements. So I'll proceed with the next abstract. So the next abstract is titled Camidanlumab, Tesserain, Efficacy and Safety in an Open-Label Multicenter Phase 2 Study of Patients with Relapsed and or Refractory Classic Hodgkin's Lymphoma. This study was presented by Pierluigi Zinzani on behalf of the co-authors and the participating centers. These are the disclosures. So we know that there are limited therapeutic options for patients who have relapsed refractory Hodgkin's and who have been unresponsive or who have failed rituximab vedotin and a PD-1 blockade agent. So novel agents are required to address the unmet need in these patients. Camidanlumab Tesserain is an antibody drug conjugate, which comprising of a human IgG anti-CD25 monoclonal antibody, which is conjugated to a potent pyrrolobenzodiazepine dimer warhead. So essentially, as you can see here in this picture, the antibody drug conjugate targets the cell, is internalized and transported to the lysosome, where a protease-sensitive linker is cleaved, and the pyrrolobenzodiazepine dimers are freed into the cell. And what they do is they develop intrastrand cross-links with the DNA, which leads to cell death. Now, treatment with Cami, as it will be referred to from now on, demonstrated encouraging anti-tumor activity and manageable toxicity in a phase 1 clinical trial that included patients with relapsed refractory Hodgkin's lymphoma. These patients received Cami at a dose of 45 microgram per kilogram and achieved an overall response rate of 86.5%. In the initial findings of in the initial phase 2 study, which included around 50% of the patients of the phase 2 study I'm discussing now, they achieved an overall response rate of 83%. So here, the authors presented the preliminary results of this phase 2 study after meeting the target enrollment of 100 patients. So this is an ongoing phase 2 single-arm multi-center open-label study in which patients with relapsed refractory Hodgkin's lymphoma received Cami at a 30-minute IV infusion on day 1 of each 3-week cycle. In the first 2 cycles, the dose was 45 microgram per kilogram, while from cycle 3 onward up to a year, the dose was 30 microgram per kilogram. Here are the key study endpoints. The primary endpoint was overall response rate, as assessed by a central review committee. And secondary endpoints included duration of response, progression-free survival, the proportion of patients who went on to a stem cell transplant, and safety per frequency and severity of the adverse events. Here are the inclusion and exclusion criteria. Regarding the inclusion criteria, I'd like you to focus on one of the criteria, which is that patients had to have received at least 3 prior systemic therapies, or at least 2 if they were ineligible for stem cell transplantation. And all patients had received prior therapy with rituximab vedotin and PD-1 blockade therapy. Regarding exclusion criteria, I'd like you to focus to one of the criteria, which is a history of neuropathy considered of autoimmune origin, such as polyradiculopathy, including Julian-Barrett syndrome and myasthenia gravis, or another CNS autoimmune disease. Here are the baseline characteristics of the patients. At the data cutoff in March 2021, the number of patients enrolled was 117. The mean number of cycles the patients received was 4.6. These patients, I must emphasize, were heavily pretreated. As you can see, the median number of prior lines of systemic therapy was 6. And practically all patients, as you can see, had received prior brentuximab vedotin and PD-1 blockade therapy. Regarding the table with the characteristics, I'd like you to focus on the autologous stem cell transplant. Practically half of the patients had failed autologous stem cell transplantation. And if we look at the disease status after the last line of systemic therapy, you can see here that 56.4% of patients were refractory to the last systemic treatment they had received. Here we can see the overall response rate. It was 66.3%, as you can see, with 27.7% CR and 38.6% partial remission. A proportion of patients discontinued treatment because they went on to hematopoietic stem cell transplantation. These were 9 patients. I'll just report that of these patients, of these 9 patients, one died due to disease progression 1 year after a haploidentical transplant, while the other 8 patients were still alive and being followed up at the time of data cutoff. Now, if you look at the results in the context of the prior analysis, I will just, this is on the right-hand side, you can see the data I just presented. But if we go back to the phase 1 study on the left-hand side, you can see the overall response rate was 86.5%, which compares higher. But the median duration of study duration was 10.3 months. And if we go to the preliminary data of this phase 2 study, again, the follow-up was slightly higher, 6.1 months, and the overall response rate was 83%. So what the authors want to say here is that because patients were assessed for disease at the first time point was at 6 weeks, as you can see here, the responses, the red triangle corresponds to complete remission, the blue triangle to partial remission, and the black box to stable disease. But as you can see, at the time of the second assessment, many patients convert into PRs or CRs, suggesting that with more mature follow-up of the study, the overall response rate will increase. Here is the Kaplan-Meier curve of duration of response. It was not reached after a median follow-up of 5.1 months. Here you can see the progression-free survival, which was 9.2 months, but not achieved for patients who had achieved a CR. And here we can see the most common adverse events. Here you can see on the left-hand side, adverse events that developed in at least 20% of patients. If we focus on the grade 3 or above adverse events in at least 5% of patients, those the adverse events that of note is hyperphosphatemia, micropapular rash, thrombocytopenia, anemia, and lymphopenia. Regarding dose delays or dose reductions, we can see that almost half the patients needed adjustment, and 13.7% of patients discontinued treatment due to toxicity. Now, what about the parallel benzodiazepine associated adverse events? As you can see here, of note, 65% of patients developed skin reaction or nail disorders, 26% developed liver function test abnormalities, and 12% developed edema or effusion. If we look at fatal adverse events, there were 3 deaths in the study. One was from myocardial infarct, which was considered not related to treatment. One due to respiratory failure, considered unlikely to be related to treatment. And one from adenovirus infection, again, considered unlikely to be related to treatment. Now, if we focus on the polyradiculopathy and the Julian-Barrett syndrome, you can see that 6% of patients developed one of these autoimmune neurological events. There were 2 patients who developed, as you can see, radiculopathy, and one developed polyneuropathy. In both of these patients, with appropriate treatment, they recovered, the adverse event resolved. While of the 5 patients who developed Guillain-Barré syndrome, in one it resolved with appropriate treatment, but in 4 patients, the syndrome was still ongoing. So what are the conclusions? So in this study, we see favorable response rates in heavily pretreated patients who had failed rituximab vedotin and a PD-1 blockade agent. And with overall response rates of, as I demonstrated, of 66% and CR rate of 27.7%. And although the overall response rate data still continue to mature, though the duration of response was encouraging and not reached, the time to event data continues to mature with time. Now, regarding the safety signals, compared to the phase 1 and the preliminary phase 2 results, the safety profile remains consistent with no new findings. And regarding the Guillain-Barré syndrome and the polyradiculopathy, it remains of concern and definitely warrants swifter countermeasures when we have patients who develop these symptoms. So we should be aware of this, and they should be rapidly treated with intravenous immunoglobulin, plasma exchange, and/or high-dose steroids. So this finishes all. Thank you.
Thank you, Dr. John, for excellent
Sorry, I'm trying
presentation.
to stop sharing. Okay.
Yeah, we'll just move to the Q&A. Okay, so there is no questions from the audience. Just here, one question. Okay, so predictor for response to Nivolumab. So any like any patient that you could, for example, early relapse after autologous transplant versus late relapse after autologous transplant. Any other predictors for response to Nivolumab?
Well, if you're talking about this specific study, there was no data analysis on this issue, but I think early or late responders, the response to immune checkpoint inhibitors is similar, I would say. Now, regarding predictors of response, apart from time to relapse, I mean, we know very well that immunostaining for PD-Ligand 1 and can predict, and we know from Margaret's SHIP study that by FISH, if you patients who have amplification of the PD-Ligand 1 gene are more susceptible to responses, but we don't do this in clinical practice. I wouldn't say that there are any specific tools to guide us which patients will respond and which will not.
Okay, would you consider Nivo after allo in case of relapse after allo, after auto?
Well, the answer is yes. There's no contraindication to give Nivolumab after allo stem cell transplantation. There have been some suggestions that it can exaggerate GVHD, in particular in patients who've been who had chronic GVHD or acute GVHD prior, but I don't think it's a contraindication. The answer is yes, I would give it.
Okay, so I think no more questions from the audience. Thank you, Dr. John. I think we're going to conclude this session, and we'll be back after 20 minutes after Al-Maghrib prayer, inshallah. Thank you.
Thank you.